elaborate introduction which may not be deserving, but nonetheless, we are grateful to Physician Forum of India and Sushil Chauhan in particular, who has been having this series Wednesday after Wednesday. Today's topic has been about the diagnosis and treatment of the Parkinson disease or the tremor disorders. Dr. Mukesh Kumar is one of the leading neurologists, but I have not met him personally either. And sorry that I will not be able to give a detailed introduction of Mukesh.
No issues, sir.
So I would like to request Dr. Mukesh to please introduce himself onto the forum, and then we can be in touch with you on a bigger platform in time to come.
Thank you, sir.
Just to introduce the topic, it's not a...
it's a Parkinson and movement disorder. I will combine it.
Yeah, that's right. It's not a very uncommon disorder. Like tremors, we do see in our practice very often on. And we need to evaluate them clinically and then go to what is the cause of these tremors. There's involuntary tremors, there's a voluntary tremors, there's intentional tremors. There are many types of tremors. I would request Dr. Mukesh to elaborate on these various aspects of tremors and their diagnosis and abreast us with the latest advancements in the treatment of the subject. Over to Dr. Mukesh.
Thank you, sir. So let me introduce myself first. I'm Dr. Mukesh. I have done my DM Neurology from All India Institute of Medical Science, New Delhi. And I am practicing in Max Hospital since 2010, since January 2010. And I am more inclined, or my more favorite topic is Parkinson disease and movement disorders. And in recent era, we are now more inclined towards a deep brain stimulation surgery, and I am myself is a DBS programmer. So I myself interested more about the DBS programming myself instead of asking the company guy, and focus on the improving the disability of all types of movement disorders. So my main focus is of movement disorders. Now, let me start with the topics. So movement disorders is mainly of two types. One is hypokinetic disorder and hyperkinetic disorder. Means hypokinetic means your the engine component or your working component is less low, and whereas hyperkinetic means your working or your engine is working at fifth gear or even more than that. So that we define hypokinetic and hyperkinetic disorder. So if you see this basal ganglia is the mainly, we can say that it is a clutch and gear of a car or clutch and gear of our body. So all the communications which starts from the brain, which communicates to our limbs, upper limb or lower limb, has to pass through the basal ganglia, and basal ganglia moderate the speed. Means the purpose of moderator of basal ganglia is to make a what we say clutch and gear vehicle into an automatic vehicle. Okay, so this makes it a more automatic, so that the speed, range, clutch, everything gets coordinated. So in basal ganglia, if you see the putamen, the basal ganglia, caudate nucleus, substantia nigra, and brain stems, all helps in regulating and modulating the disease. This is something like a gear system. So gear system is that if there is a straight flow, then it is a speed, and if it is a flow in turning, then it is a less slow activity. So among hypokinetic disorder, most common is Parkinsonism. So what is Parkinsonism? Parkinsonism is a combination of tremor, slowness, akinesia, rigidity and rigidity, bradykinesia, and positional instability. So any 3 out of 4 is required for diagnosis of Parkinsonism. So whenever we term Parkinsonism, we have to prove there should be some slowness along with tremor or tendency to fall. So among Parkinsonism, the commonest components are idiopathic Parkinson disease, multiple system atrophy, progressive supranuclear palsy, Lewy body dementia, vascular Parkinsonism, and drug-induced Parkinsonism. The Parkinson disease is the second most common neurodegenerative disorder next to Alzheimer's, and it is seen in 1 to 2% of population of over 60 years of age. It is uncommon, less than 50 years of age, and its prevalence increases with age, and it is 4% in the after 70 to 80 years of age group. In the pathophysiology, what happens? The dopamine vesicles, the dopamine gets connected to your surface, and then it activates your motor system, and it starts in the substantia nigra and regulates the whole of the basal ganglia. So this deficiency of dopamine leads to slow activity, or we can say that in layman word, our vehicle gets stuck in first or second gear. It is not moving into the third or fourth or fifth gear. So what pathology, if you see, it's the same like a basal ganglia. So what happens? There is a depletion of pigmented neurons in substantia nigra. There is a reduced dopaminergic output. Inclusion bodies develops degeneration, and then there is a neurons becomes more active than usual in inhibiting the activation of cortex, and then there is a Parkinson. So what are the clinical features? As we told, slowness, rigidity, position instability, and resting tremor. Okay. So after this, the main features of tremor. Tremor is a pill rolling tremor, slow tremor. It's mainly in the arms, legs, feet, jaw, and tongue, and it is usually present at rest, and it aggravates when distracted. But the important component, it improves on. It improves just. So it improves on distraction and at rest. And then there is a second component is rigidity. Rigidity is usually cogwheel rigidity in the upper limbs, lead pipe rigidity in the lower limbs, and it usually increases tone whenever the opposite arm moves actively. Just for example, this is one of the typical features. So where you can see the tremor is there, slowness of activity is there, and the most important component is difficulty in turning around on the bed. Turning around, and that turning around, instead of taking one step, the person is required to take 5 to 10 steps, and forward stooping posture. All together, it shows features of Parkinson. And then there is a component is like a freezing. If you see, the walking is normal, but as she turns, and then she gets stuck. This is termed as freezing, like something like this. So this is one of the features which is short steps, shuffling, and freezing gait. This is the features of the Parkinson. So the clinical features, whenever there is a bradykinesia, which is slowness, is in the form of difficulty in initiating movements, reduced blinking, poor rapid fine movement, and facial immobility. Among them, the other component is the fourth component, which is tremor, rigidity, akinesia, and position instability. Particularly, the loss of posture reflex, difficulty making turns, and retropulsions. And then patient try to run towards to catch the gravity. So what are the clinical features? In gait, there is a forward stooping posture, slow in difficulty in initiation of walking, shortened steps, rapid small steps, tendency to run, fascination, reduce arm swing, and impair balance. And usually falls starts in the later stage of the group. So this is the clinical features. You can see the stoop posture, tremor, mask-like faces, armed faces, hips and knees are slightly flexed, and rigidity, and then this tremor. So if you see in general activity, what are the things which gets troubled? So everything gets troubled, including eating, visual cueing, and this freezing and this freezing. So Parkinson disease, you need TRAP. So you need 3 out of 4: tremor, rigidity, akinesia, or position instability. And any 3 of them, if it is there, then you can tell Parkinson. If it is isolated tremor without slowness, then it is not Parkinson. So sometimes we got confused whether it is a starting tremor, whether it is a starting of Parkinson, or it is just an independent tremor, maybe enhanced physiological tremor or essential tremor. Other important features is micrographia, means there is slow writing, slow speech, hypomania, shuffling gait, drooling of saliva, difficulty swallowing, depression, autonomic dysfunction, but it is a usually late presentation of the Parkinson. So Parkinson's is mainly divided into two parts, primary Parkinson's and secondary Parkinson, means infectious because of the encephalitis, because of the drugs, because the drugs, particularly levosulfurides, or any type of antipsychotics, toxins, stroke, accident, and metabolic, something like that, calcium-related metabolism. Atypical Parkinson syndrome is corticobasal ganglion degeneration, which is quite rare, in which the one side it gets a different type of alien limb phenomena affected side. Progressive spondylosis, in which there's eye movements gets abnormal and there's a frozen of eye movement. Multiple system atrophy, it means there's a urinary incontinence and postural hypotension. Lewy body dementia and normal pressure hydrocephalus. These are the atypical Parkinson's. Among only normal pressure hydrocephalus is treatable, rest everything is non-treatable. So to say Parkinson's, what we need a history of repeated stroke with stabilized rotation, which supports the possibility of vascular Parkinson's, repeated head injury, which is sometimes as pugilistic headache or pugilistic Parkinson's or dementia pugilistica. History of encephalitis like Japanese encephalitis, any neuroleptic like any antipsychotic or like risperidone or levosulfuride or mirtazapine or other types of antipsychotic continuous usage may lead to Parkinson's. Sustained remission and strictly unilateral features after 3 years is features of the Parkinson's. Atypical is supranuclear gauge palsy, cerebral sign, autonomic involvement, dementia. Dementia is usually seen with PSP. Gauge palsy with PSP, cerebral sign with MSA, autonomic involvement with MSA, and cerebral tumor, and MPTP exposure. This is toxins which is usually used by farmers in the field. So what are the Parkinson's? The secondary other Parkinson's which has less rapid progression and deterioration within 2 years to 6 years. Multiple system atrophy, autonomic failure, cerebral involvement, or pyramidal tract degeneration, progressive supranuclear palsy, paralysis of eye movement, pyramidal sign, cognitive impairment, Lewy body dementia, early progressive dementia, nocturnal wandering, drug-induced Parkinson's, symmetrical disease, younger patients and taking dopamine antagonist. Vascular Parkinson is usually sudden onset, static progression, minimal tremor, lower limbs are affected more than upper limbs. Radiologically, what you need? So whenever you see the Parkinson, the most important is to identify the drug history. Is there any component of the drug which is leading to dopamine depletion or dopamine shortage of the dopamine in the body? And then after that, you have to exclude the structural lesion, like doing the CT, MRI or PET CT, so that you can see that there should not be any mass lesion or any other thing which gets missed. So like PET CT or SPECT shows a hypooptic of basal ganglia, and which improves after the implant. So typical MRI features are atrophy of the basal ganglia, and there is some heavy metal depositions of subthalamic nucleus as well as the basal ganglia. Next, we have to exclude a secondary cause by using a biochemical test or genetic evaluation. The systemic approach, there should be presence of one or more movement disorder. All types of movement disorder should be identified. That define the dominant movement disorder, means whether it is a Parkinson's, cerebellar, or pyramidal. Then identify the clinical based syndrome, then give diagnosis, then diagnostic workup and diagnosis. This is the clue. This program or this flowchart is mainly meant for something like which we see a cerebellar plus Parkinson component, cerebellar plus autonomic component, cerebellar Parkinson with dementia. So when we have multiple things together, then we go in this type of approach. The treatment of Parkinson's depends upon all levodopa and everything around the levodopa, means in form of dopamine or dopamine agonist or dopamine modifiers or any anticholinergics. So more important medication is giving levodopa. Levodopa is drugs which whenever you give it, it is available in two forms. 100/10 form, or 1:10 ratio, or 1:4 ratio, which is 125 milligram, 100 is by and 25. 25 is a carbidopa and 100 is levodopa. In 1:4 format, it gives you more availability of dopamine to the brain. So almost around 100 milligram, only 8 to 10% is available, gets available to the brain, and it works in the brain. So whenever we start levodopa, the activity starts in 45 minutes, and the continuity of the medication and the effect may last for 3 to 4 hours to maximum up to 5 hours. What purpose of dopamine agonist is to increase the effect of the levodopa, and the effect may go up to 6 to 8 hours. So other drugs just gives you additional benefits. So your main treatment is levodopa, syndopa, levodopa or carbidopa combination, and dopamine agonist, particularly two drugs, ropinirole or pramipexole. Drug therapy levodopa is preferred drug, usually used in early stage, and it is well tolerated. And side effects, its common side effect is something like nausea and something like hallucination in cases of Parkinson, particularly with PSP or MSA. So levodopa, whenever you give it is generally metabolized with two types of enzymes, which is one is COMT inhibitor, and the second is what we say carbidopa or benzaldehyde. So these two helps in increasing the level of dopamine in the body. Dopamine agonist, it is anti-Parkinson therapy. The normal movement, there is a low dopamine level. So dopamine agonist helps in replacing the dopamine at the required site. MAO-B inhibitor is an enzyme that metabolizes dopamine, and by giving an inhibitor, which we increases the level of availability of dopamine to brain. What happens whenever whatever dopamine we absorb, 70% gets denatured or gets deactivated in the intestinal wall. Then 20 to 30% get entered into the blood, and then even while reaching to the brain, most of them get disintegrated and only reach 5 to 8% reaches the brain. And to increase up to 10 to 12%, we need usage of enzyme inhibitor, particularly carbidopa, dopamine decarboxylase inhibitor, then MAO-B inhibitor, and COMT inhibitor, catachola O methyl transferase inhibitor, which is entacapone or entacapone, and that will overall lead to availability of the dopamine in the brain up to 10 to 12%. So the entacapone increases the overall on effect of the levodopa. So whenever we start in the early Parkinson disease, we usually start with the dopamine and dopamine agonist, and depending upon that, we increase the importance. The drug class is levodopa, which is cinemet monotherapy. COMT inhibitor is adjunct therapy. Dopamine agonist is monotherapy. Carbidopa is monotherapy. MAO-B inhibitor is monotherapy. Continuous L-dopa, which is some form of infusion or apomorphine infusion. Monotherapy or anticholinergic is monotherapy like benzoxide, triazepam, biperidine, or phenadrine. Mild to late Parkinson disease, a tricky business is dyskinesia and on-off fluctuation, drug-resistant motor syndromes, more non-motor symptoms, more medication, so more side effects. So motor fluctuation, what are the motor fluctuation? Motor fluctuation is that after taking the medication, sometimes symptoms doesn't improve. Means unexpected off, or without taking a medication, the patient feeling unexpected on. Then there is a freezing or rapid deterioration. Means you take the medication, no effect happens. So you take the medication, a freezing happens. So whenever you feel a motor complication in form of dyskinesia, in form of unexpected or fluctuation, then you think of changing the medication or going for the surgery. And the most important surgery is deep brain stimulation surgery. Earlier we are using ablation surgery, which usually now ablation surgery is obsolete, and we have usually go for the deep brain stimulation surgery. Deep brain stimulation surgery usually modified. We will come back. There are some motor symptoms which does not respond to medical adjustment. Is medicine as well is posture instability, gait freezing, fatigue, dysarthria. What are the non-motor symptoms associated with Parkinson? Psychiatric depression is depression and anxiety. autonomic dysfunction, blood pressure, genitourinary, sleep-related disorder, particularly behavior disorder, fatigue, and psychosis. These are the non-motor symptoms. And most common depression, anxiety, which needs consideration like psychotherapy of caregivers as well as the patient. So, autonomic symptoms, particularly the posture fluctuation. The most important thing is reduce the antihypertensives, reduce the diuretics, and reduce the dopamine agonist and Parkinson related medication. And we have to monitor 3 minutes, means supine posture, and then standing BP after 3 minutes, and at the end of the 3 minutes. And postural fall should not be more than 30 millimeter of mercury. And what we use, increase water, and then finally some medication, particularly the fluocortisone, midodrine, or roxidopa. Midodrine and ephedrine and fluocortisone is available, and we use a combination of fluocortisone or midodrine to control the orthostatic hypotension. Urinary symptoms is non-pharmacological symptoms. The bladder antispasmodics is oxybutynin, mirago, and other retention. Constipation, usually we use dietary fibers. Sleep-related problems is usually fatigue or REM sleep behavior disorder, in which what we say, the patient goes to sleep, and after 1.5 hours of the sleep, during the dream sleep, patient try to enact or move limbs like dreaming in the like activity and dreaming or enjoying the dream. So they can go for even sleepwalking, and they can even come out of the bed, move around, and after 15 minutes come back to bed and forget about what happened to him. This is termed as RVD, and RVD usually need clonazepam. Some cases may have hallucination and dementia, and usually that is related to Parkinsonism, not related with Parkinson disease. So what are the surgical management? Surgical management is ablation treatment or DBS. Now coming to DBS. This is something like is now in common practice. What we put a wire up to substantia nigra, and that wire gets connected to the pacemaker in the chest wall, and it stimulates the wire and increases the dopamine in the brain, and that leads to overall. So you can see the electrical neural activity, which is so much hyper, with diminution it gets controlled. So that overall functioning we see with deep brain stimulation surgery, like deep brain stimulation wire, the pacemaker, and the pacemaker programming, which controls the rhythmicity of the amplitude, frequency, and pulse width. And with this, we regulate the movements. So the usually potential complications are hemorrhage, stroke, infection, but the chances of this type of complication is less than 1%. The selection should be always with Parkinson's disease with motor fluctuation, particularly something like a freezing phenomena, unexpected on dyskinesia. These are the indication for the deep brain stimulation surgery. Just for example, I'm giving you 3 cases. Okay. Like this is on table. This area we are focusing on the DBS. On the right side, you are seeing the tremor. And if you see, the opposite side, left leg is moving almost normal, while the right leg is tremor. So on the affected side, means the right side of DBS, now you see the stimulation is off, tremor is increased on the left side. So this is the on-table performance of the deep brain stimulations, and the same patient after the surgery, almost running. This patient is running after the DBS, which is usually this type of movement is not possible. There is another case. This is the young patient, young onset Parkinson. You are seeing the dyskinesia, the head movement. is not able to start. This you can see the dyskinesia. But after the surgery, see, diminution of stress, usually medication is off, and you can see the dramatic improvement. Okay. This is significant control. Another case, this is the same case now. So this is one case which we have done recent, and you can this patient is on pacemaker or DBS for last almost 8 years. The second programming is done, and this is patient good. Usually, this type of DBS stimulation we usually advise in patient who have age of onset in by 45 years of age, of 45 to 50 years of age. In such cases, it works excellent. Now the secondary Parkinsonism. Secondary Parkinsonism are like MSA, PS, progressive supranuclear palsy, corticobasal ganglionic degeneration, and normal pressure hydrocephalus. Among them, I will more focus on the normal pressure hydrocephalus because this is a potential recoverable and completely curable type of Parkinsonism. So you can see the magnetic gait. Normal gait, you can see the stance. The two steps goes in different direction. Parkinson gait, small steps. But NPH gait is something like a magnetic gait. It is like your foot gets stuck in the on the floor. It is like a glued to that. There is some component of dementia, urinary incontinence, and there is a triad of cognitive decline, the rapid decline in the walking, and as well as urinary control, loss of control. So this is one of the important example. This is, you can see the small steps. This is before the lumbar puncture, and see now, after the lumbar puncture, it recovers completely. So what we do in surgery NPH, we monitor the pressure, we remove the CSF, see the outcome, and then put a wire, put a pipe from ventroperitoneal shunt, so from the brain to the abdomen, and it gets a continuous recovery, and it's one-time surgery, no follow-up, and just the patient remain at home or enjoy the life. So what are the diets? Diet related with Parkinson is something like levodopa absorption is impaired by ingestion of amino acids, and high fiber diet helps in mobilizing the fluid intake. And the final component is the physiotherapy. The physiotherapy, when they just, you see, the physiotherapy important point is how you walk. Whenever there is an advanced type of Parkinson, we usually a laser line and ask the person to walk like a thumb up gait or army style gait, and that usually helps in this type of attaining this type of walking. And the target gaze after this, it is all this. Okay. So with this, I just want to show another thing, which is the other type of movement disorders. So starting with the hyperkinetic movement disorders. Hyperkinetic movement disorders is the 7 types. The most important is tremor, then hemivalismus, akathisia, neuroleptic manner, and dyskinesia. So movement tremor. Tremor is isolated entity. It is a part of Parkinson as well as it may happen independently. As you see in the, this is type of action tremor. And so the tremor is not while taking rest. If you see the other hand is no tremor. But while action, this left hand is showing the tremor and person is not able to move the even water. So it is a most common and it is a rhythmic isolation, and how you differentiate. So whenever you take rest tremor is Parkinson, action tremor is essential tremor, and whenever you reach a target and then you will see like something like this is termed as intention tremor. Intention tremor is cerebellar tremor, essential tremor is genetic type of tremor, and then rest tremor is usually Parkinson type of tremor or pill rolling tremor. So how you differentiate? it is a differentiation based on the frequency. The Parkinson tremor is 3 to 5 Hz, essential tremor is 5 to 10 Hz, orthostatic tremor is 12 to 18 Hz, and cerebral tremor is less than 4 Hz. Another component of movement disorder is dystonia. One type of dystonia which is common where you see is blepharospasm, and facial dyskinesia and hemifacial spasm. Where this is adductor dysphonia. It is laryngeal dystonia. So dystonia may be focal, segmental, or generalized. Okay, so focal dystonia is usually in the cervical dystonia, blepharospasm, spasmodic dysphonia, writer's cramp. Segmental dystonia is in entire limbs, and multifocal dystonia is in the whole body. And it is depending upon the cause: focal dystonia, primary dystonia, dystonia plus syndrome, and secondary dystonia because of trauma, stroke, drugs, and even encephalitis. Then the last is motor tics. Motor tics, this type of movement is, if you see, short lasting, suppressible, repetitive movement of eyelid or something like a face or something like a hand or something like this type of shoulder. This is termed as tic, and the most common disorder is Dilla-Tourette syndrome. It is subpermanently suppressible, abnormal movements, and it is two types of motor tics and verbal tics. Verbal tics means abusive language. Then the common is chorea. Chorea is like a semi-purposeful movement of the whole body or in the hand. In children, it is particularly Sydenham's chorea, and in old age, it is Huntington's chorea. Like example, see, this is Huntington's chorea, or Huntington's chorea like illness. You can see the fidgetiness of the whole body. This is not tremor. It is fidgetiness. It is also in the proximal. Usually, tremor is seen in the distal part, distal fingers, and it is usually seen in the proximal part. That's why it is we can say the proximal plus distal. It is chorea. It is like a generalized and purposeless, irregular, rapid flowing, non-stereotyped and random involuntary movement. Most common Sydenham chorea. Other most common is Huntington's disease. Other disorder is myoclonus. If you see short lasting, something like this, shock. This is ocular myoclonus, and this is the hand-written myoclonus, mostly on the left side. It can be a presentation of the seizure. Yeah. It may be positive or negative. Negative myoclonus is usually seen with liver disorders or kidney disorders. This is athetosis. This is athetosis in the affected limb, and this is a non-repetitive, semi-purposeful, bizarre movement. And this is balismus. And none of this, the least one, but the most common one, what we see is this, tardive dyskinesia. Commonest. After tremor and dystonia, this is the one of the common, and always it is related with some form of drugs, some form of antidepressant or antipsychotics. Okay. So, how to treat? The most of the movement disorder, essential tremor, every movement disorder or essential like a tremor or thing has a typical different types of treatment. For tremor, essential tremor, we use beta blocker or primidone. For dystonia, we use haloperidol, tetrabenazine, and pacitine. Sometimes even we use Syndopa. In akathisia, clonazepam, or akathisia, hemibalismus, clonazepam work. In chorea, valproate works. And in tardive dyskinesia, what important is the withdrawal of the antipsychotics. So, with this, how you approach? Approach is mostly radiological to see the damage to the brain and to see the atrophy of the brain. And then we proceed depending on the treatable and the non-treatable outcomes. Thank you, sir.
Thank you, Dr. Mukesh Kumar, for a very exhaustive talk on Parkinsonism and Parkinson's disease and the various movement disorders. It is really very enlightening to all of us, and you brought out very simply and very pictorially all the symptoms, and so it is very easy to understand. I think a lot of questions will be there by the house. May I request the house to shoot the question. I have one question to ask you in last. Let Dr. Tulsi come on the phone.
Yeah.
Tulsi sir.
Okay, thank you, K Mathur sir. Dr.
Yes,
Mukesh,
sir.
as Dr. Mathur said, what a nice presentation, and especially the cases that you showed, very illuminating cases and really very interesting ones. Now, the International Movement Disorder Society have identified the three most common movement disorders. That is essential tremors, restless leg syndrome, and of course the PD or the Parkinson's disease.
Yes, sir.
Now, the essential tremors being the most commonest, especially in the elderly, incidence is ranging from 8 to 20%. What is the incidence do you think it is in India? Of course, it depends upon the age. So, roughly, average incidence of essential tremors would be how much?
Sir, that I don't know exact words, but it is not. It is less than the Parkinson.
Okay.
Usually, essential tremor is a hereditary tremor. Essential tremor usually we see after 40 years of age. In general practice, in neurology practice, we see essential tremor in almost one case every week. This type of essential tremor with running familiarity, usually we confuse with enhanced physiological tremor and essential tremor. So it is not more than the Parkinson disease. It is less than the Parkinson disease, and it is usually hereditary.
So this is contrary to what I thought. Essential tremors are more prevalent than
they are enhanced physiological tremor and anxiety related tremor. Essential tremor, you have to prove the geneticity most of the case. There is a family history.
So would all essential tremors have a genetic history or family?
Yes, sir. Yes, sir. That is a features. Otherwise, it is enhanced physiological tremor.
Okay. Now, Primidone, as you know, is one of the only two frontline drugs.
Beta blockers and Primidone.
Let me complete, sir. For essential tremors, now this drug is associated with considerable adverse drug reactions, so-called Primidone intolerance, and it's unclear why these adverse events are more prevailing in essential tremors than Primidone-treated epilepsy. What do you have to say about that, sir? Is it because of the older age and the GABA-related abnormalities associated with essential tremors?
Sir, the issue is that whenever you treat essential tremor, we start with the beta blocker, particularly the propanol. Propanol controls, we increase the dose up to 40 to 80 milligram, and then we add Primidone. In Primidone, the use in epilepsy is 500 milligram a day. In essential tremor, we use 25 to 50 milligram a day. Okay. So, whatever the side effect you have mentioned is usually seen with after more than 250 milligram per day dosage, not with 25 or 50 milligram dosage. So, we use the Primidone in essential tremor in doses of 25 milligram per day to maximum up to 100 milligram a day, and this type of side effect is usually not seen in essential tremor. In my practice, usually 80% of essential tremor gets controlled with beta blocker. Primidone is not required. Primidone is required in less than 10% of cases in combination with beta blocker.
So my question was different. My question was why the adverse drug effects are more seen with essential tremors than with epilepsy, than in epilepsy.
Primidone currently is only used in essential tremor, not used in epilepsy at all. Nobody uses in epilepsy.
Okay. But it has been seen that there are no side effects or adverse effects if used in epilepsy.
Actually, no, sir. It is suboptic or suboptic optic neuropathy, myelooptic neuropathy, which is seen in Japan, which is one of the serious side effects of Primidone. That's why it is discontinued in usage as epilepsy.
Okay, so any interesting future therapeutic options available apart from beta blocker or rather propranolol and
deep brain stimulation surgery?
No, I'm talking about future therapeutic options in the sense that
DBS. Medicine, no other option, sir.
No other option. Gabapentin would not help.
Doesn't work.
Doesn't work. And you already talked about Parkinson's and Parkinsonism very vividly. Now, do you do the L-DOPA challenge in your hospital when patients to
Yeah.
see if the patient is responding to levodopa, to see the response and observe the side effects like hypotension? Do you do that?
Yes, sir.
Okay, so okay, and as you already talked about levodopa having off and on time and dyskinesia at peak medicine levels as the PD progresses.
Yeah.
Now, often we see that the dose needs to be up titrated, and with that the side effects appear. Now, I wanted to ask about whether you are doing the DAT SPECT test. I'm
No,
talking about the radioactive markers to
not required.
track dopamine in the brain.
No, not required.
Not needed. Okay.
Not needed.
Now, sir, about the DBS, when would you? What is the correct time to start? This therapy. Would you wait for the drugs not working and then start?
Practically,
What is the ideal time to start a DBS?
whenever you feel there is a syncope-induced dyskinesia or leg shivering movement on the starting of the dopamine, then you need, whenever the motor fluctuation starts, then you need it DBS.
Okay.
That's the earliest point.
Okay. Now, DBS is no longer an option if you do not respond to
Syncope, yeah.
L-DOPA or
Yeah.
Syndopa.
Yeah.
So you must respond to this drug for the DBS to be effective. Is that true,
Yes.
sir?
True.
Okay, wonderful, sir. Thank you, sir.
Thank you. Yes, sir, Dr. Kalra.
Sir. So nice, sir. After such an exhaustive spell of questions by Dr. Tulsi, my first comment, sir, you mentioned about clutch and gear.
Yes.
So you have excluded accelerator. Is there any accelerator also?
Accelerator is brain, sir.
If you are talking about a car, accelerator has to be there.
So it is not accelerator. It is an engine.
Anyway.
Is an engine. The engine and accelerator is together.
Okay.
Okay.
So
and now it is getting transformed. The energy has to transfer from brain to the limbs.
मैं इसको वो कह देता हूँ ना, एक कंसेशनल वो कर देता हूँ कि एक क्लच गियर, जैसे ब्रेक है, क्लच है, गियर है.
हाँ, ये तीनों together. ये that together. Clutch, gear and brake together.
So coming here, I would just like to know, as we are talking about inhibition of inhibitions. So what is the role of alcohol? It also inhibits the inhibitions.
Okay. What happens with alcohol? Essential tremor, alcohol is one of the treatment.
तो मैं ले सकता हूँ.
Modestly, but try to understand that as a medical practitioner, we cannot write taking alcohol as on prescription. So
ETOH लिख देते हैं सर आजकल.
तो वो ऊपर लिखते हैं, ETOH abuse लिखते हैं, ना कि नीचे treatment advice में लिखते हैं.
So I'm making things lighter, sir, just for my friends.
So ETOH is required for treatment of essential tremor. Means after one peg, usually tremors recovers completely.
Right.
Completely, and it lasts for almost 4 to 6 hours.
Can I call it back in half an hour?
The second thing is the alcohol, what reduces the effect of syncope.
Right.
So it increases bradykinesia, means your slowness will aggravate.
It's a double-edged weapon.
It's double-edged.
So
It controls the tremor, but it increases the slowness and tendency of fall. So
Right.
overall, for Parkinson, it has adverse outcome. For essential tremor, it's a good outcome.
Sir, so just don't mind my lighter questions because my questions will start now.
Thank you.
Firstly, sir, about drug-induced Parkinsonism or whatever, I want to inform my friends that levosulfide is so commonly used and it's one of the notorious drugs to cause it, PD. So Parkinsonism-like symptoms are very much common with levosulfide, and pentoside L is being used very frequently by many of us.
Yes.
So we should know that if it is used for long, it may have symptoms like that.
Yes,
What's your comment?
No, it's true, sir. Actually, recently, I considered that there is one lady, she came almost frozen, wheelchair. Okay, and I first spotted the medication. She was on levosulfide for 4 months. I stopped it, started Syndopa, and asked to come after 48 hours. She came walking.
Right.
But what happens? Levosulfide induces Parkinson in the person who is inclined to have Parkinson.
Right. So my next question was the same. Are there any genetic predisposition, or can we test it in beforehand?
No. Test is not possible. But if you feel there is a doubt of Parkinson, avoid giving anything. But if there is a slowness, if there is a tendency of fall, then don't use this type of antipsychotics.
Sir, we have seen at least 3 waves of COVID. Has COVID affected the incidence, onset, and the management of this Parkinsonism?
It doesn't changes the incidence of Parkinsonism, but it definitely changes the management of Parkinsonism. Now we are seeing more bedbound and wheelchair-bound Parkinson because of the discontinuation of medication or absence of the modification of the medication because of the lack of medical communications.
Like we have a nebulization system for delivering the medicine directly to the lungs. So I wish there was something to deliver something directly to the basal ganglia to have its more selective effect.
So some fetal cells was tried to put inside the substantia nigra and see the outcome. But so far all these studies are non-successful.
Sir, you mentioned about the measurements in hertz. So hertz is, I think, measurement of sound waves.
No, that is also for tremor. How many movements in a second?
So it's a frequency and modulation kind of thing.
Yes.
And as I know, very lightly I'm saying, our one of very renowned cricketer had some problem in the wrist, Vishwanath. And he had a very effective bowling. So, do some movement disorders help in the cricketing or some other skills?
It is depend upon the person's own modification of the
blessing in disguise.
Yes.
Blessing in disguise.
Yes.
So something very effective and makes the product beneficial. So,
yes.
Sir, I will stop here because many of my friends like Dr. Chauhan and others are waiting for the questions.
Yes.
Sir, my question is that when do you use Syndopa 110 versus 125? What is the advantage one over the other?
Sir, actually, it is 1:10 ratio, 1:4 ratio.
That's right. Where do we place that other one in comparison to other? Means where you like to use 110 and where you like to use 125?
Sir, I never use 110. I always use 125.
That is your. What I'm trying to say.
Why it is being used, I don't know practically. Yeah. But the standard format is you use Syndopa and Carbidopa in 1:4 format, not 1:10 format. 1:10 format provide levodopa in 1 to 2%, while 1:4 format increases levodopa availability to the brain is up to 5%. So that's a trick. So amount of levodopa delivered to the brain is higher if there is a 1:4 ratio, and if it is 1:10 ratio, the delivery is less. Sometimes in cases of Parkinsonism, where there is a high chances of Syndopa-related dementia or psychosis or hallucination, in Parkinsonism, particularly PSP or tendency to fall or MSA, in such cases, it may lead to more effect than side effect. So that maybe if you see theoretically, yes, Syndopa 110 milligram can be used in that selective cases.
My related question is there any side effect of Carbidopa?
There is no side effect. What happens? Your disease gets aggravated if it is atypical Parkinson. If it is not Parkinson disease.
What I am trying to say, suppose we start from the beginning only 125, not 110, because Carbidopa does not have any significant side effect.
Yes.
So why we should always, anytime use 110?
It is the proportion of the enzyme inhibitor, because Carbidopa itself is not a drug.
I understand what I am trying to say. Instead of using 110, we are using Carbidopa as only 10 milligram.
No, 25 milligram.
No, 110.
110 में 10 milligram.
And 125 we use 25.
Yeah.
Suppose we use 110 3 times a day, so we use 30 milligram of carbidopa per day.
Yeah.
And in the other we are using 75. So by increasing the dose, do we increase the side effect of the carbidopa? That is what I'm trying to
No. What happens whenever we give levodopa or carbidopa together? Carbidopa reduces the degeneration of levodopa in the body. So it increases.
Because decarbonation inhibitor. It is a decarbonation inhibitor. It will not
so it is not about the amount. It is just amount with syndopa, aldopa, levodopa. If you don't give with levodopa, it doesn't work.
That's right, because peripherally it will get converted to dopamine, and then the dopamine side effect will come.
Yeah.
That is there.
That is there.
Yeah. Thank you, sir. Thank you.
Thank you, sir.
Any more questions now, Sushil?
I think it was a wonderful presentation by Dr. Mukesh.
Thank you, sir.
And some wonderful questioning by Dr.
Tulsi
sir and Dr. M.L. Kalra sir and Dr. Anil Gupta sir. And I will ask some very simple questions, sir, for the benefit of the house. Sir, you are into the deep brain stimulation program.
Yeah.
But what is the cutoff age?
Cutoff age is 80.
I have a patient who is 83-year-old who has failed on syndopa, carbidopa, anticapone, pramipexole, and amantadine. Will he qualify for deep brain stimulation or?
Yeah, he can qualify, but if attendance is ready, we can try into deep brain stimulation. Deep brain stimulation usually is no harm.
What is the cost?
70 lakhs.
17 lakhs.
Yeah.
What is the maintenance cost?
Zero.
All right. And
Would you say if the patient has dementia, probably not indicated?
Not indicated, sir. Only Parkinson with past history of good.
With dementia,
No, not indicated.
But in Parkinson, freezing is not benefited by this.
Freezing benefits studies. It is all about the programming, how you program.
The freezing benefit is there.
Yeah.
all right. My patient has got a complete left bundle branch block, and I have been treating him for last 10 years.
Sir.
And Dr. Viveka has told me not to use propranolol for his tremors anymore.
So use Pacitan.
So what I have done is I have gone to increasing the dose of his dopamine. I have also introduced the drug that you call the anticapone after consultation with one of my neurologist friends.
That's the right approach.
I will add you to my friend list after today.
Thank you, sir.
And also, I have given him a trial of amantadine, but it has not worked. So his beta blockers are out. His QT is at the upper limit level. What should be my next approach to control his tremors?
Pacitan.
How much?
2 milligram. Start with 2 milligram twice a day, and then increase up to 4 tablets a day, depending upon the side effect. Particularly, side effect is dryness of mouth and sometimes behavioral changes.
Sir, he is 82-year-old. Can I?
Half tablet. Start with half tablet twice a day.
All right. Sir, you mentioned about this drug, the pramipexole. What dose should we start?
Pramipexole and ropinolol too. Pramipexole, you have to start 0.125 milligram twice a day. Increase every week by 0.125 milligram to maximum up to 2 milligram per day. In ropinolol, you have to start 0.25 milligram twice a day. Every week, increase by 0.25 milligram, and maximum you can go up to 8 to 10 milligram.
Sir, there is also an element of Parkinsonian degeneration of the brain in Parkinsonism.
Yes.
How do you take care of that?
Actually, if it is a Parkinsonism, means anything other than Parkinson, like dementia, like cerebral disorder, like rigidity, like urinary complaint, like psychotic, then only symptomatic management, nothing much.
Okay, so there is no specific treatment for that.
For Parkinsonism, means Parkinson plus cerebral autonomic or something like that, no major treatment.
Right. Now, sir, this patient, which I just talked about, he developed a complete heart block. I sent him to Dr. Viveka, and he put in a pacemaker to this patient.
Now use beta blocker.
Can we use beta blockers now?
Yes, on pacemaker, why not use beta blocker? You can use beta blocker.
Okay. So, so that would, because of the tremors, the issue of tremors.
Yeah.
Now, sir, you talked about hypokinesia, and the bottom line drug that you talked about is the dopamine.
Yeah.
Or the dopamine agonist for hypokinesia.
Mm-hmm.
Sir, how high can you go with the dose of dopamine agonist?
Dopamine agonist is ropinirole. We can go up to 10 to 12 milligram. With pramipexole, we go up to 2 to 3 milligram daily. And syndopa, levodopa, we can go up to 10 tablets a day.
Sir, can you give them, all of them?
I usually one or two, either syndopa plus ropinirole or syndopa plus pramipexole.
Sir, what is the brand name of ropinirole?
Ropark. Only one company, Ropark.
All right. Sir, you said that I can still refer this case to you.
Anytime.
And his deep brain stimulation will cost him 17 lakhs.
17 lakhs, yes.
This patient is affording, at the age of 82, can I tell him 17 lakhs means 17 lakhs?
Yes, sir. 17. 17 means 17, sir.
Doesn't mean 27 lakhs.
No, not at all, sir.
All right. Because we have seen in COVID that nothing means nothing in Max Hospital.
No, sir. Actually, in last 6 months, we have done 2 cases and it is clear. The cost is 17.
I lost my nephew in Max Hospital. And he paid 27 lakhs in a period of 6 days with ECMO being done and ECMO having failed. And it was so painful. And the members of the forum know that I don't want to say anything for Max or anything. It is just my destiny and the destiny of the family. But at times in Max, things are not in your hands, Dr. Mukesh.
I agree, sir. I agree.
So, right. It was a wonderful deliberation on movement disorders by you, sir.
Thank you, sir.
And I would leave the last question to Dr. K Mathur, sir, being the moderator of the forum.
Thank you, Sushil. Once again, repeating same thing. Mukesh, lovely talk by you and very well answered all the questions by the esteemed members of the forum. One question I would like to share with you. The repeated stroke means 1 or 2 strokes the patient having. What are the chances of developing them the Parkinsonism or tremor or disorders like post-stroke complications? Let's put this.
So post-stroke complication.
Personal question.
Post-stroke complication is usually seen with a major stroke involving the basal ganglia and or thalamus. So usually we see vascular Parkinsonism after 3 or 4 or multiple episodes of silent strokes, in which if you do an MRI, your vascularity load or vascular damage load is very high. We can see we say it as a leukoarosis grade 4. So for Parkinsonism, to explain vascular Parkinson, you should have a damage in the basal ganglia, particularly thalamus, particularly putamen, caudate nucleus, or multiple damage in the substantia nigra, and with leukoarosis.
So to follow the post-stroke, we don't have to do MRI very frequently. We just have to observe the clinical.
If there's a deterioration,
then only we have to look on it. Yeah. Any prevention or any indication that how to prevent it? Something can be prevented post-stroke.
Sir, mainly not post, but we have to reduce the chances of a stroke. The appropriate anti-platelet drugs or anticoagulation or NOAC, depending upon the risk factor of the patient.
That's fine. Treating the hypertension of the thing.
Yes.
Thank you once again, Dr. Mukesh. The lovely talk.
Dr. Carla,
my last comment, sir. Some 40 years back, when I was a student in doing my post graduation, so I as a conservative, I used to write small, you can say micrographia. But then I read about it that micrographia precedes Parkinsonism by decades. So kindly clear my doubt. I still have not developed anything like Parkinsonism, but I have intention to write small just to save paper. So how good or how bad is micrographia for Parkinsonism? Is it really true or a myth?
Sir, in Parkinson, it is not a one symptoms. It is a constellation of multiple symptoms. So you need tremor, you need rigidity, you need bradyc slowness, and you need posture instability. And micrographia is just on one symptoms related to slowness.
Dr.
So
Kalda, you
more
are
of
cognitive
miserness.
factors.
So no for of your interest.
Right, sir. Thank you so
They
much.
don't have to have apprehension, Dr. Kalda. Your cognitive factor is so strong. And your intellectual is so high. There's nothing nowhere near that level of Parkinsonism.
Yes, sir.
Anyway, since there are no more questions, I can once again thank Dr. Mukesh Kumar and the audience for all the interaction taken place. And thank you very much, everybody, to join.